that because I think, and thank you, that the digital information is so key, and it seems like, and I've only been in the job for now 9 weeks, it seems like HIPAA and other things are thrown in as barriers that make no sense to me.
They're enablers.
In Cuyahoga, we had 14,844 births in 2015. We had 155 infants passing away before their first birthday. Trying to understand those 155 is like the most difficult thing I've ever had to navigate. I worked with aging out youth, I worked in drug and alcohol, I've done some, and I don't understand that we know between our county, city, and hospitals everything we need to know about these 155. It took me so long to just figure out 70 of them were born as non-viable heart-beating babies. They were born between 16 weeks and 23 weeks. So the intervention, these are not drug and alcohol. I mean, everyone said, these are teen moms. They're not. I have not found one teen mom that lost a baby through a mortality yet. People that don't need drug and alcohol. I did not find one that had a positive toxin. But why is it that we just literally put $5 million into this issue just alone in the last 6 months into neighborhoods that say it's 36% rate of infant mortality? But that means 4 babies out of something like 600 that are delivered. People understand this. 4 babies, and I don't even know if those 4 babies got it from sleep-related death.
You got it.
And so I guess that digital infrastructure is not only important to share data, but then to be able to tell the community the real story, because the poor moms that I'm meeting in the inner city, they're like, oh my God, it's my baby. What am I doing wrong? And they may not be doing anything wrong because we are not sharing the right data.
So, are you familiar with the All of Us campaign?
Yes. I've learned a little about it, but it's just how to get them, the rest of the community up to speed.
This idea, you went a different direction than I was going to go. You're doing retrospective analysis, let's learn why. And that's a research question. So, before President Obama left office, and in a massively bipartisan vote in the 21st Century Cures Act, there basically was a program that said families should be able to, with one click, donate their health data to research and opt in. And there's actually funding right now to test what's the right way to reach underprivileged communities, and how do you, I mean, it sounds kind of creepy, Big Brother wants your data for research, what does that mean? So the country's kind of sort of figuring out what are the ways to message this. You're going to see, I don't think any Cleveland hospital is participating, but a lot of hospitals are volunteering to be early adopters of the technology. It's called Sync for Science. For those of you that are interested, Sync, S-Y-N-C-F-O-R .science, S-C-I-E-N-C-E. It's a totally free, open collaborative that any hospital could adopt. And it basically says, we're going to upgrade our portal so that if a patient wants to, with one click, push the button, they can donate their data to research. And in that case, the problem you face is linking data sets. So the child was born in hospital A, but treated in clinic B, and may have had social services C, and on other things. So stitching together their digital journey, every piece of their journey is becoming digital. There is information about them digitally, whether they themselves are sophisticated to monitor it all, it's available. And in theory, with API infrastructure, they can authorize an entity to help stitch that stuff together on their behalf. So on the research side, that's Sync for Science, that's all of us, it's free, anyone can do it. Again, I don't think anyone from Cleveland signed up for that, but a bunch of really cool places have. And then on the other side, it's what I was saying earlier, which is imagine someone enrolling in Text for Baby in Cleveland, and as part of that, if it's done wholesale, links with an initiative like, hey, enroll in this Healthy Mothers initiative, where we're going to help stitch together that service, plus your pediatric thing, and the OBGYN. So one can think about ways to do real-time intervention in a trusted, secure way, and it would feel like they're downloading an app on their phone.
So again, I want to go to Brian just now, but again, our goal this morning is to get beyond the hype and into this kind of scenario-based activity. So, you know, the infant mortality piece is huge. I know there's several in the room who could probably speak to literacy issues in our community. I'd like to invite people to kind of go down that path. I know there are folks here who are very much concerned, broadly speaking, in improving the healthcare of the community. Let's go down that path together. If we're interested in talking about digital access, and there are several folks, let's kind of go down these pathways together with Aneesh here, because the goal is to get sort of beyond the headlines and to get lots of interesting resources, but also to give Aneesh some feedback to what's going on in Cleveland. Brian?
I'm going to dare to be a little bit contextualizing in terms of issues. So on the infant mortality, I think what's interesting, when I took over the chair of the health committee about 8 months ago, I was kind of surprised looking at the Robert Woods Johnson Foundation's kind of monthly benchmarking of county health data, that we had been way on the bottom for a long time, not just the county, but even the state. So it's interesting how basically withdrawing some funds from Moms First actually caused people to say, well, wait a minute, this is really important. And then I think then we looked at the larger and said, geez, we've been really bad at this for a long time. So I bring that up only to say that for any given issue, knowing what the broader issue and the data is and kind of what targets you to do something in a macro way is very important. I would then flip it on the other side to say, from a micro standpoint, both for mortality, because most percentage is premature babies in deaths before 1, so that's a huge part of it, so it's a really micro issue to focus on. But even generally micro issues, Bill and Wanda, what they're doing with digital inclusion and digital literacy in the neighborhoods, very geographic, dispersed systems, which is challenging. But in fact, it's so connected to literacy issues, and somebody mentioned literacy as well. And I think, in terms of a micro issue, there's a lot of sexiness in big data, open data, coding programs, using data, et cetera. But the truth is, and Bill and Wanda can speak to it better, the digital inclusion part is really suffering in our urban cores in general. And we can do whatever we want with sexy, cool stuff, but if 50% of our people, or 40% of our people don't have hardwired connections, what do? So those are just some contextualizing issues.
And maybe I can ask Don to chime in. We're going to kind of, instead of just being dialogue, we'll try to make it a community-wide conversation.
I just have a couple comments here. So just on the health issue, I know the sharing of digital data is nice at times, but also you can actually share the processes. So I know the city of Cleveland itself on the health issue has health clinics, but we also have mental health. We also have really only 3 other hospitals in the city that are clinic and UH. So my thought for even the health department, I don't know if any of our health departments here today, is I would rather turn over our health management information system to mental health. Because we have these patients that go back and forth, back and forth, back and forth. So instead of sharing the data is just already there. We had the same problem when I worked in the school district was we had 67 communities and 44 school districts, I believe, in Cuyahoga County alone. Right? So, and people just move within the same year. They move within the same, between boundaries of cities and suburbs, and they go back and forth maybe 2 or 3 times a year, and you have upwards of a 25% mobility rate. So instead of each one of us having a student information system, why not just have one? I know the state has one that you send information to, but a lot of the larger systems have their own system. So it becomes, instead of trying to share data, just share the system. You can,
So Don,
that goes back to your whole story.
well, here is the dilemma. So 8 to 10 years ago, the policy debate was massively inefficient, pockets of random little capability. Let's elevate to a common standard and do a massive procurement, get economies of scale, and then we have one platform to rule them all. I have come out with the opposite conclusion, which is we're so new to figuring out the questions and the workflows we want. So this woman who's doing the mortality thing, she'll probably uncover 5 different steps that we don't do today as checklists that we want local OBs to do to hey, did you check on that? Did you get them connected to this? Did you get them a Uber voucher? I mean, whatever. And so hardwired systems that are centrally run would take her list of requirements and say, in 6 years, we'll get to item 3 on your list. So it crushes any reusability and innovation potential on that very, very critical piece of data. So I've come to the conclusion that I want many, many, many systems, but at the edge, a common language. using the way the internet operates today. So here's a goofy example. If you're a mom or a dad and you've got the world's best key lime pie recipe, there's no one database, recipe.com, that you submit everything to and share. In fact, Google, Microsoft, and Yahoo have agreed on a technical standard called the schema.org recipe standard. So if you publish it on your random WordPress blog, and you enter the appropriate metadata, which is actually quite easy, a lot of folks do it, not just the big companies. When I search key lime pie with graham cracker crust, yours may be just as important in surfaces as the others because that information is widely disseminated. No friction, open standards, very high discovery rates. And so my theory is these regulated government databases can connect to that same ecosystem with one layer. You got to have an authorization server to make sure the person's authorized to query, but that brings the internet to health, internet to education, internet to utilities, and once you get that, you get the economics of all the internet infrastructure that we've been talking about.
I'm going to ask Steve McHale, and if you don't mind, Steve Podash, to comment on that, because this is a bit of a give and take between the micro and truly internet scale macro activities. Steve, I think it'll be obvious why I'm interested in your take on what Aneesh was just commenting on, because it is, you've managed to put the internet to play in the health space in a big way. I think it's good for all of us to understand, but also some feedback for me. Thanks. I think this is
You got to turn that on. There's only one mic. You cut it. Hey, he cut you off. Hold on. Now you're on.
I deserve that. For sure. That's what you get for nodding your head in agreement.
No, I saw that.
You saw me nod my head.
No, I know. I was going to go there anyway.
Okay, great. Well, thanks. Excited to be here. This is just, let me share that. I mean, just when I saw this event, I was like, this was one I had to see, and it's great to see a lot of people I know as well with passion. And as I'm thinking about this, first agree wholeheartedly with the innovation stunting that will happen should we try to unify under large-scale systems. It would take years to get to list number priority 3. Totally agree. We've seen it, lived it. And
Can you give a color commentary on how you lived? I mean, when you set up Explorys.
yeah. So I mean, when we came in as Explorys, we figured we'd ask for forgiveness later. That was our strategy, right? We realized that we had to get to the data. Fire wasn't even out yet. I mean, the common interfaces didn't exist, so we just basically plowed our way in and did what we did in telecom and said, all right, we're going to connect to these core systems, get the data that matters, take no prisoners, and get the job done. So that was our approach. It was pretty effective, and we're seeing standards emerge now, which is very encouraging. And but I think that's what we need to see on all these different systems, that we get to a common interface that we can get access to, because that's where we can continue to innovate, like what Bernie was talking about. I think that we can get to those kinds of process changes, care path changes, whatever we want to call those, that are going to drive innovation. The one area though that really, number 5 bullet that you said, which is outcomes and values, right?
Yep.
Right there. I mean, I think that's the center of focus that's in my mind right now, which is I see so much effort and so much passion to change what's going on here. And like I asked Bernie, I'd say, what's the lowest common denominator that you can figure out that's associated with your infant mortality issue? I think I know the answer, but what do they all have in common?
Poverty.
Poverty.
No,
Yeah.
not true though.
Really?
At least the data that we're seeing, when you break it out,
Wow.
for the 70 out of the 155 that died born at a gestation 16 weeks to 23 weeks, which are non-viable, the denominator is insured African American middle class women.
So wait.
And they're insured, you're saying?
Wait.
Not just Medicaid.
Yeah, but
Insured
Yeah.
private. And those, so I think there's different. The sleep-related might have a denominator, but I'm not
That's
having
good.
enough data.
No, but this is why this is such a powerful statement. If you go to the CDC sites, there's a high correlation at the zip code that are low income zip codes have higher rates of infant mortality. So one could read.
That's the numbers I'm running off.
And that is explicit, absolute clear. What she's doing is mashing up. She went to the hospitals and said, give me your billing data. They had insurance. We know what kind. We could even probably check off and they went and got prenatal visits. So now you can run very precise queries if you could borrow into that raw data. You didn't really get HIPAA protection for that, so there's a little bit of a gray how you're able to do that under a research protocol or something. But if you did the all of us, then it becomes an easier thing to assemble, so you can be very granular in the hypothesis to test. And getting that right is, I think, enabling infrastructure for actually solving this problem, because this disconnect is the frustration. I
Right.
promise you, we have made assumptions and policy
Yeah.
on aggregate statistics that look right. They're not wrong, but when you get micro,
You can see more
you
of the
see
data.
more detail and the
Yeah.
eyes open. But that's not known. How many of those moms listen to their get text or messages, but didn't show up for their prenatal? How many was their no-show rates? You could really, there's so many, and all of that is digital. So we're not even having to manually enter stuff. You're just saying, let me grab the scheduling hose for that patient. Let me grab the lab
Sure.
values for the patient. So our problem is access to the data in a form that can be studied, and that then gets to enabling infrastructure. What is the way to do that? And again, I'd say all of us is one framework for research, and these other, but yeah, keep going.
Yeah, I mean, I just put it down on it, which is, I believe that we are coming to a time where we have to move to outcomes driven. Everybody that's in this room,
Yes.
if you connect us all together and say we have the same vision and let's now agree on outcomes
Yeah.
and unify around that, then you have a very different scenario in the next 5 to 10 years. And that's what I think, that's what the talk's going.
And